Thank you very much, Kate, and for the kind introduction and for the invitation to be here to join you for the launch of the report. As the Prime Minister set out very clearly this week, the NHS faces some significant long-term challenges: an ageing and increasing population, an increasing burden of chronic disease, rising costs of drugs and new treatments, and growing almost insatiable public expectations. If we choose to ignore these pressures, if we stick with the status quo, then in the years ahead the NHS will face a real crisis. That would threaten the core values of a comprehensive health service available to all, free at point of use, based on need. And this government will not allow that to happen. But given the financial context within which we have to live, how do we ensure the NHS is not only sustainable in the long term, but that it gets better? That it gives the people of this country healthcare that is consistently amongst the very best in the world? I think the answer is straightforward. You put the right people in charge, you make it crystal clear what it is they are trying to achieve and how they will be held to account, and then you do everything in your power to support them in what they are doing. If they need extra powers or resources, as far as you can, you supply them. Where there are obstacles, you remove them. That is what happens every day in successful organisations around the world. And it is what I want to happen in the health service too. Today is about leadership in the National Health Service, about what good leadership can do for patients, and about how we can support and nurture current and future leaders within the service. Please note that I say leaders, not leader. For leadership in the health service cannot be about one person at the very top. The leadership style of Henry V on St. Crispin's Day, the man on horseback approach, may be dramatic and inspiring, but it isn't appropriate for something as vast, as complex, or indeed as subtle as the National Health Service. The service needs far more than that. It needs leaders at every level, in every institution, and in every profession. And the people that I believe first and foremost should be those leaders are the clinicians in the service. General practitioners, hospital doctors, nurses, pharmacists, allied health professionals, scientists. We need people in every area to step up to the plate and lead. No profession can be left out if we are to deliver truly integrated, high-quality healthcare for everyone in the country. When I talk about every profession, I include management. Leadership and management, however, are not one and the same. Some managers are leaders in the service now, like David Nicholson. Others will be leaders in the future, but not just because they rise up the managerial ladder. Management is one of the professional disciplines in the NHS, but it is a support discipline to clinical professions, not a substitute for it. But just so there is no confusion, I do understand that high-quality managers are essential to the effective and efficient running of the NHS. No fundamental change in any NHS organisation ever came about without the support of managers, people who are every bit as committed to the health service and to improving patient care as clinicians. The problem is not the people, it's the system. Managers are placed in an impossible position. Too often in the health service, change is seen as a process whereby managers tell clinicians what to do. But why is this the case? It's because people like me in government in the past are constantly ordering them to do it. So you end up with a top-down command and control system with the health secretary of the day driven more by the day's headlines than the best interests of patients. He then gets officials to come up with some ploy that he can sell to the press, tell the NHS managers to carry out, and then claim to be saving the day. Tends to be only that day. Managers are then left to force it through on the ground, whatever the clinicians might think, or whatever the consequences down the line for patients. Exciting initiatives with new names, but which often amount to very little in the end. The result? Emasculated and frustrated clinicians, overstretched managers caught in the middle, and patient care that is at the political whim of whoever happens to have won the previous election. And over the years, The accumulated weight of countless initiatives to implement, targets to meet, reports to produce, boxes to tick, meant that the NHS wasn't sufficiently well managed. It was over-bureaucratised. Managers are no more free to run their organisations, often in the NHS, than clinicians are. Over the last 7 years, more than 7 years, that I've been both Shadow Secretary and now Secretary of State, I promise you, it has as often as not been the managers running organisations in the National Health Service who have said to me, we've got to get rid of a top-down tick-box culture, as it has been the nurses and doctors saying it. And while those who work in the National Health Service have just simply added frustration to their job description, it's patients who lose out on the potential benefits of a truly clinically led health service. Unfortunately, what I've described is not new. It's been around for decades, but it cannot continue in future decades. It's time that politicians and indeed managers gave more control to the people who really understand the needs of patients and how to serve them best. That is, patients and their nurses, doctors and other clinicians. Today, the King's Fund's report, Commission on Leadership and Management in the NHS, has been published. I very much welcome this report. It speaks to the same ambition I have for the NHS, for a service led from the front. An integrated NHS that is focused on improving clinical outcomes and nothing else. A service that is well managed, not excessively administered. I understand the caution around the size of reduction to management and administration budgets at the moment, but remember, most of this will come from the abolition of primary care trusts and strategic health authorities. In any case, across all the public services, similar reductions in administrative costs are required. In the NHS, we can see now how we can achieve this by changing the shape and burden of administration, not simply reducing the numbers of administrators. Keeping the system the same and asking fewer people simply to do it would have been an unsustainable approach, and it would not have released, well, if it had released the resources that we require to invest into the front line, it would have done so only by reducing the performance of the NHS. What we need to do is to release resources to the front line and improve performance. And by handing power to clinicians, by ending constant micromanagement and overburdensome performance management of the NHS, much of this work in administration can be reduced. Where I fully agree with the report is in the vital importance then of high quality leaders and managers. The gains made in recent years must be maintained and built upon. Every NHS organisation and provider must take their staff development role incredibly seriously, especially new entrants from the charity and independent sectors. So I'm very keen to continue the excellent work of the National Leadership Council. I was with them last week and I announced that we would fund a further 60 fellows as part of the Council's fellowship programme, developing tomorrow's leaders from all parts of the service. Every one of those will make their own individual mark on their local NHS, but collectively they will make a real and lasting difference to the level of leadership within the NHS as a whole. Now, the King's Fund report says the NHS needs a national focus on leadership and would welcome a National Leadership Development Centre. I can tell you I am actively considering how we can achieve such an objective. I know there are interesting and novel schemes already up and running. For example, the innovative programme at UCLH, which has drawn on models of leadership from within the armed services. We'll respond to that and other recommendations once our present listening exercise has ended. I said at the beginning, if you want to achieve success in an organisation, you first have to put the right people in charge. But that's not all. You then need to be clear about what they are trying to achieve and show them how you will hold them to account for that. So let me ask you a pretty simple question. What's the NHS for? Actually, we all know when we see it. It's for supporting childbirth, promoting good health, treating illness and injury, promoting recovery, care for those with chronic illnesses, care for those who are dying. But if we know that's what the NHS is for, why have we never measured in a systematic way how well it's achieving those aims? Of course, these things are not always easy, but they are worth the effort. What is the gain if you treat people in a shorter period of time, but the quality of the care and the quality of the outcome for the patient declines? Too often we measure the success of the health service by the number of units it processes, not by how well it improves people's lives. So from now on, I want all parts of the NHS to be judged on the clinical outcomes that are achieved. By publishing the outcomes framework last December, we are helping all clinicians across the service to pull in that same direction. Reducing avoidable mortality, enhancing recovery after treatment, improving the quality of life for people with chronic conditions, maximising safety and cutting the number of infections, and continually improving patients' experience of their own healthcare. We're developing those outcome framework, and to support the NHS in delivering those outcomes, NICE is developing a library of condition-specific quality standards. These will mean that over time, every clinician and every patient will be able to see just what excellent care really means and judge whether they are receiving it. These aren't targets by another name. They state what should be achieved, but not how clinicians should achieve them. As General Patton once said, "Don't tell people how to do things, tell them what to do, and let them surprise you with their results." Well, David Cameron and I were very clear, actually over 5 years ago, when we said we are going to move to an NHS where we, on behalf of the public and the taxpayers as a government, are clear about what we're trying to achieve, but we will not tell the NHS how to do it. It is the job of people who manage the care of patients to lead in determining how we best achieve those results. And because all providers of NHS care will be aiming for the same high quality outcomes, I believe I and the NHS Commissioning Board, the commissioning consortia, the local authorities, and most importantly patients themselves will be able to hold providers to account for delivering that excellent care. And more often than not, delivering excellent care means delivering integrated care. Unfortunately, the NHS is not particularly good at integration. What it's good at is episodic care. If you're young and relatively healthy but fall ill with a specific disease or have a particular injury, the health service is excellent at taking you in, making you better, sending you on your way. The problem with this is that the vast majority of the people the NHS looks after don't fit that description. Most of today's patients are older and with one, or more often more than one, long-term condition. So you have a typical example of an older person with terminal cancer having to rely on a member of the family coordinating care between a general practitioner, a community nurse, a hospital, a social care, in fact sometimes more than one hospital, and social care. But trying to manage that coordination themselves, because actually there doesn't seem to be a mechanism by which all of those things are joined up properly. And what about the many who don't have somebody doing that? Who don't know how to fight their corner? What happens to them? The needs of patients are too often not fully catered for by the strengths of the National Health Service. And the result is too often care today in the NHS is fragmented. A patient with COPD might be treated by her GP, by a pulmonary specialist, by a community nursing team. 3 separate groups of people to contact, 3 separate sets of forms being filled in, 3 separate notes to keep track of. All this with the patient in the middle, often the one who has to try and coordinate their own care between them. Or look at the example of end-of-life care. Most people want to die in their own home. But the fact is most people actually die in hospital. This isn't because of the high level of intensive hospital-based care they actually need. Very often, it's because people who work in the NHS aren't able to provide the very best care to their patients at home. It isn't set up to deliver that. The system of tariffs doesn't encourage it. The people with the money in primary care trusts aren't often aligned properly with clinicians in designing it. It's hard for the voluntary sector in end-of-life care, absolutely critical to the provision of service. Organisations that add so much to the care for people at the end of life, it's hard for them to offer their services into an integrated structure. Patient experience and outcomes aren't measured, and all too often health and social care organisations just don't join up. But there are examples where people have joined together to make the system work. Since 2004, Marie Curie Cancer Care's Delivering Choice programme has taken a whole system approach to end-of-life care, working across all those involved, NHS, voluntary sector, social services and carers, to provide 24-hour patient-centred care for those at the end of their lives. The evaluation of the first scheme in Lincolnshire carried out by the King's Fund found that deaths at home increased in proportion from 19% to 42%, while deaths in hospital fell from over 60% to just 45%. All the while actually cost neutral. It was about improving quality, not reducing cost. Another important opportunity for joined-up services is in urgent care. They're too often fragmented, varying in quality across the country, and with patients often confused about which services they should go to. Whether they should go to A&E, whether they should call out of hours, should they go to the walk-in centre, should they ring 999, what is it they're supposed to do? Should they ring NHS Direct? All of these services. By adopting new technologies to encourage greater self-care, by introducing the 111 telephone number as a single point of contact for non-emergency care, and by giving local commissioners the freedoms and the responsibility they need, we can change this. We can deliver a more integrated urgent care system that turns the NHS into a 24/7 service and makes phrases like out of hours increasingly feel redundant. Care needs to be organised not around the needs of a particular provider, but around the needs of the particular patient. To have good care, care needs to be integrated. Another thing that is essential for achieving excellence is involving patients in their own care. That means more than just explaining things to people, it's bringing them into the decision-making process. It means giving patients a real choice. Now, patients already have a degree of choice. They can choose the hospital, carry out an elective procedure. Or at least they could, if they were able to distinguish to any meaningful degree the quality of care offered by one hospital from another. But whether you're going in to have an ingrowing toenail removed or for cancer treatment, if you don't know how good a particular service is, how can you, and for that matter your referring general practitioner, decide which to choose? And even if you look at the current overall hospital ratings, they won't tell you how good their clinical outcomes are at the one thing you're most interested in, at the procedure you're about to have. So while patients today theoretically have a choice, often it's hardly a choice at all. So is it any wonder although almost all GPs maintain they offer patients a choice, Anna Dixon's research here at the King's Fund showed fewer than half of patients recalled being offered a choice. We do need to offer choice where appropriate. Even more so, we can make the framework for choice more robust. If you could see not only how good a hospital was, but how good a specific department or even a specific consultant-led team was, wouldn't that change things? That is when GPs and other clinicians can really draw a patient into the decision-making process. For with the right sort of information and advice, choice becomes meaningful. And patients will choose the care that offers the best results for them. Last month, the National Cancer Intelligence Network published for the first time mortality rates 30 days following surgery for bowel cancer. Across the country, the average figure was 5.8%. That national figure masked, however, a huge variation, from 1.7% at one end to 15.6% at another. Now, you and I know there may be good reasons for some of that variation, but there won't be good reasons for all of that variation. And we can see, as we have done, for example, in cardiac surgery, how to identify those results, to get those results properly case mixed, adjusted and validated, to publish those results and to hold people for those results actually transforms outcomes. It has in cardiac surgery taking us from a position where we were below European averages in terms of results from cardiac surgery to a position where we are among the very best. Now, see, because those figures don't tell you that care in one place is necessarily better or worse than elsewhere, but it does give the clinical teams in the first place real pause for thought. To ask the question, is there more that we can do to look at those with the best performance and see if there are things they are doing that they are not? Making that information available to the public will then have an impact. It was a decision the cardiac surgeons made for themselves, and it made an impact. Patients with their doctors able to make a more informed choice as to whom they should be treated by. And given the choice between one hospital with a very high survival rate and another with a very low one, which would you choose? How often have clinicians across the NHS thought to themselves, I know where I would be treated, I know where my mother should be treated, I know where my child should be treated. That is a sense of the information, the understanding and the choice that every patient should be able to access. Now choice, real choice, means that providers of healthcare services will sometimes be in effect in competition for patients. They are now. Strengthening information and accountability will encourage though all healthcare providers, however good they may be, to raise their game and to offer patients the best possible care. No healthcare provider, whether NHS, charity or independent sector, should be competing on price. As we extend tariff, as we are clear about prices being fixed for all providers nationally or locally by the commissioners, the only way to distinguish yourself as a healthcare provider should be to provide a higher quality service than others. But at this point, some people start to question whether competition isn't utterly at odds with that other essential ingredient I've mentioned, proper integration of healthcare. Now let me explain not only why this is not the case, but why competition can actually lead to a greater degree of integration than would ever be the case without it. To do that, I hope you'll forgive me for a moment if I leave the realm of healthcare. We live in a complex world where we take for granted actually the minor miracles of integration that we see and experience every day. It's so seamless, we don't notice it. I bet virtually everyone here today has a phone or a BlackBerry or something like that in their pocket or a bag. Some of you will have more than one. That's not too sad, I suppose. It might be a basic model where you can make calls and send texts, that's about it, or increasingly a smartphone that can do everything bar the washing up. Either way, you are enjoying the fruits of countless individual organisations operating in a wide range of actually highly competitive markets, but working together to deliver one complex, ubiquitous product. Actually, it includes mining companies, designers, chip manufacturers, haulage companies, marketing agencies, engineers, precision engineering, logistics, data management, network providers, warehouses, and retailers. Each one competing fiercely for business at every step of the way. Each one successful in large part because of the high degree of integration they can offer with the other parts of the supply chain. Where organisations compete but don't offer to integrate their services, you know what the result is? They don't get any business. It's in the interest of every provider to offer the greatest possible degree of integration, even with those whom they might otherwise be in competition with. Vodafone and T-Mobile both rely on common standards. We have mass sharing. Whether you have a Nokia, an iPhone or a Samsung, actually the same SIM card will work in all three. Because actually that's what we're looking for as consumers. And in healthcare, as commissioners of healthcare and as patients, we should demand the same degree of integration, and that actually then competition will drive precisely that degree of integration. Of course, the NHS isn't a mobile phone. It's nothing like that. It's infinitely more important than that. If things go wrong on your phone, actually you get a bit of peace and quiet for a bit. If things go wrong in the health service, people's lives are at stake. Modernisation, therefore, isn't about competition for its own sake. It's about improving results for patients. It's about building quality services for patients. It's about extending information choice. It's about competition as a means to an end, not an end in itself. And it means ensuring that the service is patient-centred, not provider-centred. And that's where we put competition, at the service of patients, not obstructing those whose job it is to deliver the best possible care for patients. I know clinicians in charge of commissioning will demand nothing less, because it will be an essential element of every relationship in the NHS, because they will be rewarded for the outcomes they deliver, and they will be better if they are deeply integrated within wider pathways of care. Everyone that I'm talking to across the NHS in our present listening exercise is emphasising to me, commissioning consortia, providers of healthcare, they want to design new pathways of care. They want to improve the clinical design of services. They know we need to respond to the challenges that I mentioned at the outset, and they want to be given the tools to do that job. So a hospital that doesn't go out of its way to integrate its, for example, its general surgery with community nursing teams and rehabilitation and with local general practitioners, they will simply run into problems. The community dialysis provider that does not link up with specialist community nursing, with renal specialists or with social organisations will find it very difficult to convince commissioners that they should contract with them for their services. If nothing else, if they don't prioritise integration, others will. And they will be the qualified provider that commissioners go to. And in those circumstances where the best care is provided by commissioning a single provider across the whole pathway, that's allowed too. The bill does not prevent that. It will support the needs of patients and the decisions of commissioners. It's about doing whatever it takes to produce the best outcomes for patients. Now, if we agree the whole point of the NHS is to provide the best outcomes for patients, then I believe we need a fully integrated NHS that is clinically led and gives patients real choice. I'm clear that's what we must achieve. And we are, at the moment, making clear how open we are to views and ideas about how we can best achieve it. To my mind, nothing is more important than getting this right. I can entertain any amount of change in the bill if I know that it is in the best interests of patients. And the law of unforeseen consequences should play no part in our future structure of legislation. We should be clear about where the duties and responsibilities lie, and our present pause to listen, to reflect, to improve is about getting the legislation right to support the NHS in the future in making that happen, making sure it does not get in the way of the future change which will be driven from within the service, not driven from the legislation or indeed from the Department of Health. So that's why we paused after the bill left committee, to listen, to reflect, and to do the things, substantive things, that will mean that our ambitions are matched by reality. The bill is necessary not to give more power to the centre, but to give it away to the front line. You cannot have a clinically led system without the legislation necessary to effect that devolution of power, responsibility and budgets. And if you want the NHS to be truly run from the front line, you do at some point need the people at the top to let go of the reins of power. I can see there are plenty of people in this audience who have heard me say in the past, and it is now true, and it is now my intention, that if we want to empower patients and clinicians, doctors and nurses across the NHS and health professionals, we have to disempower others. And it isn't management that we disempower. Actually, it's the bureaucracy that we disempower. It's those tiers of management that have got in the way of enabling the people who manage the care of patients to take responsibility for the service design that goes with best delivering that care. And that is what the Health and Social Care Bill is all about. I don't want the future of the NHS to be determined by me or any other politician. I want it to be determined by the millions of choices made by millions of individual patients and by 1 million healthcare professionals right across our service. By the local NHS and social care working together with patients and patient representative groups and carers to bring cohesion and integration to patient care. And by thousands of clinical leaders in general practice, in hospitals, in mutual and social enterprises, in the charity and voluntary and independent sector right across the country. The government will put the right people, clinicians, in charge. We will make clear what they need to do. We will make clear how they will be held to account. And then we will do everything possible to support them in their difficult responsibilities. That is our vision for the National Health Service, a vision of an NHS led from the front line, a vision that puts patient care above news headlines. A vision I believe in, I fully expect to deliver outcomes that are consistently amongst the very best in the world. Thank you very much.